Welcome to the deep dive. Today, we're getting into the clinical weeds of type 2 diabetes mellitus, or T2DM. And this isn't just a high-level overview. Our mission, based on the source materials, is to give you the operational blueprint, the exact pathways for diagnosis and management.
That's right. We're talking about the step-by-step approach from the emergency room triage all the way to long-term care. It's a journey that really relies on specific lab numbers and a tiered system for treatment.
Okay, so let's start at the absolute foundation then, the basic mechanism. What is actually going wrong in the body?
Well, at its core, any type of diabetes means glucose can't get from the blood into the cells for energy. But T2DM has a very specific beginning. It starts with something called insulin resistance.
Okay.
Think of insulin as the key that unlocks your cells. With insulin resistance, the locks on the cells, especially in muscle and fat tissue, they just get rusty. They stop responding to the key.
So the key itself is fine, but the door won't open.
Exactly. And the pancreas, which makes the insulin, it sees all this sugar stuck in the blood and it panics. It starts working overtime. The beta cells just pump out more and more insulin to try and force those doors open.
So for a while, a patient might actually have higher than normal insulin levels.
For years even. That's the body compensating.
Yeah.
But it's not sustainable. Eventually, that constant high demand, it just burns out the beta cells. We call it beta cell dysfunction.
They get exhausted.
They get exhausted, they stop working efficiently, and then they can't make enough insulin anymore. And that's when the blood sugar stays high. That's the clinical start of T2DM.
That makes so much sense. And that failure point brings us right to the first and maybe most critical decision for a clinician. When a patient shows up, are they stable or are they unstable?
That is everything. It's the first question. And you answer it with the ABCDE assessment: airway, breathing, circulation, disability, and exposure.
So if the patient is crashing, all the focus is on stabilization.
Immediately.
Yeah.
You're thinking about managing their airway, maybe even intubation. You're getting IV access. You're pushing IV fluids. If their blood pressure is low from dehydration, it's all hands on deck.
Because we're dealing with acute life-threatening crises. And there are two big ones we need to name here, right? HHS and DKA.
Precisely. Hyperosmolar Hyperglycemic State, or HHS, and Diabetic Ketoacidosis, DKA. And these patients, they're often too confused or, out of it to even tell you what's wrong.
So you have to rely on family for the history. Things like extreme fatigue, headaches, that classic intense thirst and urination.
Right, the polydipsia and polyuria.
Okay.
Or maybe they had an infection or just ran out of their meds. And the physical exam, it tells the story. They're confused, they have a fast heart rate, low blood pressure, dry mouth.
But the real distinction, the way you tell HHS from DKA, that comes down to the labs.
It does, and this is where it gets really interesting physiologically. HHS is much more common in T2DM, and DKA is the classic for type 1, but it can happen.
So what are the numbers? What are you looking for in those labs to draw the line?
For HHS, the random blood glucose, the RBG, is just profoundly high. I mean, we're often talking over 600, and that leads to an incredibly high serum osmolality, usually over 320. The blood is just super concentrated.
And DKA is different. The blood sugar is high, but maybe not that high.
That's right. With DKA, the RBG is typically over 250, but the osmolality is often normal. The real smoking gun for DKA is on the blood gas analysis, the ABC or VBG. It shows an elevated anion gap metabolic acidosis.
So why is that? Why the difference in the acidosis? It must go back to the insulin.
It goes directly back to it. This is the key insight. In HHS, the patient still has just enough of their own insulin floating around. Remember that slow beta cell burnout?
Yeah.
That tiny bit of insulin is enough to prevent the body from breaking down fat for fuel, a process called lipolysis. No fat breakdown means no ketones, and no ketones means no severe acidosis.
But in DKA, there's basically no insulin at all.
Almost none. So the body thinks it's starving and it triggers massive, rapid lipolysis. All that fat breakdown creates a flood of acidic ketones, and that's what causes the metabolic acidosis. It's a completely different metabolic state.
Wow, okay. That really clarifies the link between the lab and the mechanism. But for either crisis, the immediate management is similar.
It is. It's aggressive IV fluids, first and foremost, then correcting electrolytes, especially potassium, and then maybe an IV insulin drip. And critically, you have to find and treat whatever tipped them over the edge, like an infection.
Stabilize the system, find the fire.
You got it.
All right, let's pivot now to the much more common scenario. The stable patient in a primary care office. The ABCDE check is fine, but you suspect T2DM. What are the clues?
You're looking for those classic symptoms, of course. Weight loss they can't explain, the thirst, the urination, but also big risk factors. Are they over 45? Do they have a family history? A history of gestational diabetes?
And there are some physical signs, too, things you can actually see that point to insulin resistance.
Oh, absolutely. Beyond just looking at their weight, we look for something called acanthosis nigricans. It's this dark, velvety thickening of the skin, usually on the neck or in the armpits.
Oh, it's like a Brecht marker.
It's a huge visible sign of severe insulin resistance. We also do a careful foot exam to check for early nerve damage, what we call peripheral neuropathy.
Right, with the monofilament test.
Exactly, checking for numbness or abnormal sensation.
So once that suspicion is high, it's time for the labs to confirm the diagnosis. There are 4 main tests, right?
Yep. Hemoglobin A1c, random blood glucose, or RBG, fasting blood glucose, FBG, and the oral glucose tolerance test, the OGTT. And for you listening, knowing these specific numbers is the shortcut to understanding the whole diagnostic process.
Okay, let's lay them out, starting with that warning zone with prediabetes.
Prediabetes is an A1c between 5.7 and 6.5%. Or, if you're using a fasting test, an FBG from 100 up to 126. The 2-hour OGTT would be between 140 and 199.
And that's a critical window, isn't it? That's
It
the
is.
chance to intervene.
It's a huge opportunity. The main thing is intensive lifestyle modification. Diet, exercise. For some very high-risk patients, we might even consider starting metformin to try and head off full-blown diabetes.
Yeah.
And you have to rescreen them every year.
So what are the hard numbers that push someone over the line into a confirmed diagnosis of diabetes mellitus?
Any one of these will do it. An A1c of 6.5% or higher, a fasting glucose of 126 or higher, a random glucose of 200 or higher, but that one has to come with symptoms, or a 2-hour OGTT result of 200 or higher.
You hit one of those, the diagnosis is made.
The diagnosis is made.
But the work isn't done. Now you have to figure out if it's type 1 or type 2, even in an adult.
That is such a critical step because the treatment is completely different. We use specific blood tests. We check for autoantibodies, things like GAD65 and ICA2 antibodies. If those are positive, it points to an autoimmune attack, which is type 1.
And what about the C-peptide level? What does that tell you?
C-peptide is made at the same time as insulin. So it's a proxy for how much insulin the pancreas is actually producing. To confirm T2DM, we need to see negative antibodies, so no autoimmune attack, and normal or even high C-peptide levels.
Which proves the pancreas is still making insulin, the body's just resisting it.
You've got it.
Okay, T2DM is confirmed. Now we get into management, which is tiered. And it all hinges on one number, the patient starting A1C. Let's do scenario A, a new patient with an A1C between 6.5 and 10%.
This is the most common starting point. We begin with metformin, which is an oral medication that helps reduce glucose production from the liver. And of course, you pair that with aggressive lifestyle changes.
And you can't just set it and forget it. The follow-up is key.
Absolutely not. You have to see them back every 3 months to recheck that A1C. But just as important is the yearly screening for the long-term complications.
What does that yearly screening look for?
We're looking for damage to small blood vessels. So a retinal exam for retinopathy in the eyes, a thorough foot exam for neuropathy, for nerve damage, and blood and urine tests for nephropathy or kidney damage, specifically an EGFR and a urine microalbumin.
Now, what if at that 3-month check, the A1C is still too high? Let's say it's still 7% or more.
That means the initial therapy isn't enough. We have to escalate. And this is where modern treatment gets really personalized, because the choice of the second medication depends entirely on the patient's other health problems.
So things like heart disease or kidney problems will guide the next choice.
Exactly. If the patient has known cardiovascular disease, heart failure, or chronic kidney disease, the guidelines point us very clearly to one of 2 classes of drugs.
Okay.
For patients with heart failure or kidney disease, we prioritize a class called SGLT2 inhibitors.
And those do more than just lower blood sugar, right? They're actually protective.
They are. It's fascinating. They work by making the kidneys dump excess glucose into the urine. But they also seem to protect the heart and kidneys by reducing fluid volume and pressure and changing how the organs use energy. It's really organ protective pharmacology.
That's a huge deal. What's the other main option for that second agent?
The other class is the GLP-1 receptor agonists, or GLP-1 RAs. We lean toward these if cardiovascular protection is the goal, or if weight loss is a really high priority. They also have strong data for reducing heart attacks and strokes, and they help people lose weight.
So you're not just treating the number, you're treating the whole patient and their specific risks.
That's the essence of modern T2DM care, risk stratified management.
Okay, let's tackle scenario B. A patient shows up and their A1C is already 10% or higher. This suggests a really significant problem from the start.
It does. An A1c that high means the system is just completely overwhelmed. You have to be much more aggressive. Initial therapy here is starting basal insulin. That's the long-acting, once-a-day kind and a GLP-1RA, often in the same injection.
Why both at the same time? Why not just insulin?
Because you get two different benefits. The insulin directly tackles the high glucose and gives the pancreas a much-needed rest. The GLP-1RA is added for its cardiovascular benefits and to help with weight, which is important because insulin itself can cause weight gain.
And then you can add short-acting insulin for meals if you need to.
If you need to, yes. And the follow-up is still every 3 months, but the lab work is a bit more intense. A1c, of course, but also a basic metabolic panel to watch the kidneys and electrolytes. And the yearly complication screenings are non-negotiable.
And I'm guessing you can still add an SGLT2 inhibitor on top of all that if they have heart failure or kidney disease risk.
100%. The SGLT2I is often seen now as an organ protection drug, and you add it if that specific risk is there, no matter what else they're on.
So when we put this all together for the listener, what's the big takeaway? We've gone from the root cause all the way to this very personalized tiered system.
The main takeaway is that T2DM management is a series of very precise decision points. Knowing the lab differences between DKA and HHS saves lives. And knowing those threshold numbers, the 6.5% for diagnosis, the 7% that signals you need to add a drug, and the 10% that means you need insulin now, that provides the whole framework for care.
It's about understanding the complexity, not just the label of diabetes. It explains why treatment today is so focused on protecting organs using these specific drugs like GLP-1s and SGLT2s.
Exactly. And I want to leave you with one final thought focused on that management loop. T2DM is not a one-and-done prescription. It's this constant 3-month cycle.
The moment of truth every 3 months.
It really is. That A1c check dictates everything. Do we stay the course? Do we switch drugs? Do we escalate? If you miss that checkpoint, the patient is at risk. And it's this relentless need to constantly adjust therapy, balancing the sugar against the risk of organ failure, that really defines the challenge of managing this chronic disease.
A continuous reassessment. It proves that the most important part of the treatment is often the diligence of the monitoring itself.
The markers are the map. You just have to follow them.
Thank you for joining us on this deep dive. We'll catch you next time.